Welcome to this Global Healthcast special brought to you by Global Health Press. The topic today is the European health data space. We talk about data innovation in data collection, in data safety, and potential benefits to our populations. I am Joe Schmitt, and with me today is Professor Dipak Kalra. Good morning and welcome to our presentation.
Good morning, Joe. Thank you very much for inviting me to speak with you this morning.
I do have the title slide already up here, and maybe you explain a little bit about your institution.
That's very kind of you, Joe. If you could actually move to the next slide, it may be easier. So I am one of the founders and the president of the European Institute for Innovation Through Health Data. We are a not-for-profit organization headquartered in Belgium, and our mission is to help catalyze better uses of health data across all stakeholders so we get the maximum value for the opportunity to learn from health data. We work across stakeholders, and we are neutral because we don't ourselves have any data, we don't use health data. We exist really to help find good solutions that can help everybody else to get the best value from data.
So I see here your institute really has different stakeholders or different interests that are mentioned here in the circle. The one question I have looking at this is what is the place for data protection in your institution?
Well, it's very important. So of course, as we are an organization, we do have some data that we have ourselves that we look after, and so we have our own data protection officer, and we have our own internal data protection policies and safeguards. But really our big energy on data protection is not us, but helping those who have data and those who use data at scale to adopt good practices. The GDPR is a critical and really important European regulation with which everybody has to comply. And it's, in a way, relatively easy. Inside delivery of healthcare, hospitals and GPs are very familiar with how to protect data. And if you take the opposite end of the spectrum, clinical trials, there's a long history in knowing how to look after data well from a clinical trial perspective. But when we want to take real world data and reuse it across these stakeholder groups, we're entering an area where best practice and best adherence to the GDPR is more difficult to specify. And so we find it very helpful that we can provide education, training, good practices in how to conduct big data research in an ethical and protecting way.
Very nice answer. So in essence, what it boils down to is you help people use data protection to come up with appropriate data and make best use of them. This is the way I understand it.
Absolutely, absolutely.
So what is the spectrum of data use? Can you explain a little bit? I think you have it on the next slide. What is up here?
So it's probably, I mean, there are just so many uses of health data. It would take, hours to think going through the whole lot. But this is going to prove quite a busy slide. You don't see it yet. But it's easier perhaps to think about the uses of data at the level of the individual person whose data it is, the population, which could be at the level of a hospital or a health region or a country, and then big data, which is increasingly multinational. So if you could just click once and let's just take a look at this list. So these are just examples of the ways in which we need to really use individual health data, for example, to monitor individual patients, increasingly, I think, to use telehealth to connect a patient in their home to a healthcare professional, to offer continuity of care, to look at how patients are traveling along a care pathway, and to use a little bit of algorithm to give feedback and guidance to patients and clinicians. There's increasing interest in personalized medicine, making the treatments that we give patients even more relevant to them and helping not only with disease, but actually prevention and well-being. Topics like reimbursement too. And if you could click again for me, please, Joe. Then if we're looking at bigger populations, not the individual, then healthcare providers can use that information on a collection of patients to look at their performance, to make plans, and to set up the way that their care pathways are designed so they optimize the quality and the safety of care. Often you need to calibrate medical devices and refine algorithms to make them relevant to your own local population. And then if we look at a slightly bigger group of patients, then looking at safety issues like pharmacovigilance, I think today none of us would really doubt the importance of public health given COVID. We all know that's important. But we also need to understand more about diseases and treatments, and that's where we need increasing volumes of data. Often we find for some things like rare diseases, a whole country isn't big enough. We really need to collaborate across countries so we can advance epidemiological research and understanding of diseases, invent better devices, sensors, wearables. AI development needs big data in order to be accurate, personalized medicine, drug development, diagnostic development, and so on. So we really have a huge spectrum of opportunities to learn from data.
This is certainly very nice how you split it up. So you have data from the individual, you have data from, let's say, a country, and then you have big health data globally. And by bringing this all together, everybody has additional value. It's like creating something new from what exists already. Now,
that's our hope, absolutely.
Yeah. Looking at it specifically from a research angle, I see this is all real world data. This is not a double-blind randomized study, but it is data that are out there in the population already and that may be of benefit. So I asked you the very aggressive question. What you're doing is against the Cochrane bias. You no longer look into double-blind randomized studies only. And I would even challenge you with asking you, do we need this real-world data? This is all stupid. It's not double-blind randomized.
Well, I think that's a great question, and I think it's a good call. I don't think it's too difficult to deal with, but I think we just need to be very honest with each other about the scope of what can be learned by different approaches. It's completely true that the real world contains messy patients, let's call it that. Patients who have multiple diseases, different age groups, all sorts of things going on in their lives. The data that is collected is to some extent less controlled because it's collected by many, many different clinicians or patients without using a standardized data collection protocol or template. And so you could say it's messy data collected on messy patients. And I'm using the word messy in an informal, friendly way, as opposed to the RCT, that is what you might call sanitized patients. It's patients who have perhaps only the one disease within a narrow age band, where the case for collecting data is carefully controlled. There are particular time points during a treatment plan where you collect the data, and all of the data is, maybe all the samples are processed in a single lab. So the RCT is without doubt producing gold standard data. And therefore the evidence coming out of an RCT is very, very scientifically robust. The trouble is that it's not really reflective of the real world of patients, because we have taken to task real world data contains real world, messiness, but actually the messy patients are the real patients. Patients who take a medicine, for example, will have other diseases. They will miss tablets out. They will have their data collected at different healthcare providers in different systems and different ways. So actually, real world data is realistic world data. And we need both. We do need the RCT. I'm not proposing that we throw those away, but they are undertaken at high expense with a long time lag before we get the results in carefully controlled situations. But we need reality checks, and real world data gives us that. Also, I'd like to point out that the RCT has ethical boundaries when it can be used, and I'm involved in a project at the moment called Conception, which is looking at the safety of medicines in pregnancy. It's very difficult to perform ethical randomized control trials in pregnancy because you can't easily randomize women to take a drug whose safety you haven't yet established. But real pregnant women have other conditions like epilepsy and asthma and diabetes. So real pregnant women do take real drugs. And there is therefore data on what happens to them, what happens to their pregnancy, what happens to their babies. And we would be crazy not to look at that, because from that we can start to infer a lot.
Yeah, I think this is a long but great answer. We need these data because in the end, look, during the COVID pandemic, there was no randomized controlled trial on the variants. We had efficacy data on our vaccines from the Wuhan strain, but not on the later variants that were coming up. So we used real world data. In the end, sometimes a double-blind randomized trial may come up with a highly significant result, which is totally useless. Remember Pepto-Bismol. That was highly effective in preventing traveler's diarrhea, but you had to swallow 240 milliliters of the substance a day. And you would need to carry some kilos of the substance for a 1-week vacation to Mexico, which makes no sense.
Yeah, no, that's a very good point.
Anyway, this is very interesting. And I think this may really, what you're doing may help us for the breakthrough to use more real world data. And because we want to use data in real people and not in the experimental design setting only, which again is the limitation of the Cochrane type randomized controlled studies. Yeah.
Well, I think if we can just accept that it's a strength and a weakness, that these things have to coexist.
I think exactly, it's complementary. Very nice. So. Very nice. Yeah. So you have sharing initiatives. You want to have some information.
Thank you. Yes, I just wanted to make clear that the idea of doing big data research is not wishful thinking. It is a reality. And this slide has really just got some illustrative logos on it. Initiatives that are inside countries like France and Germany, some pan-European initiatives. Some of them are simple observational groups. Others are looking at life sciences data or rare diseases. The RD platform is a rare disease platform that the European Commission has run in order to enable big data research in rare diseases where it's absolutely true that one country doesn't have enough patients for good scientific study. And all I wanted to really point out is that this is an absolutely busy, active area of national and transnational investments because of the recognition that it is vital for us to learn from big data. And yes, you can have rare diseases that are needing scale, but also small treatment effects, small personalization variations also need big data in order to verify. What you end up with is still a small number of patients, but you've maybe needed to look across multi millions in order to find that small number of patients who you can put into a real world observational study.
Very
but
interesting.
Perhaps, Joe, what I could tell you is that we are now on the cusp of the next generation of scale on this topic.
Which is what?
Well, it is the European health data space. I think at the moment, I would say across the health informatics community, right across Europe, this is the excitement point. The European Commission has launched a very bold, ambitious, highly resourced plan for data spaces in a number of sectors, including agriculture, energy, transport, and health. But they've decided, thankfully, that health should be the first. So we are actually the first data space to be put into operation, and they have launched a regulation on the topic. This regulation is a draft being debated currently in the European Parliament, but it defines a framework for member states joining forces to collaborate on making data available across borders for both patient care and research. And this slide is just the intro to a really exciting story of what the EHDS proposes to be.
So I see one benefit here, and that is all of a sudden, I, as a patient, have all my data and I have access to all my health data, which is not true for the past. I don't know who is having what, who owns what somewhere in his private practice or in his hospital where I had been a patient before. So this is really something new. And this may really help us in Europe to be a marketplace for new information, for new science, for research and development. And this is really a huge benefit, I believe. And I'm very happy to see this is the first let's say, big data space in Europe, right? This is really exciting.
Yes, I think it's going to be the biggest data space for sure. So it's very nice that you've raised the issue of the individuals, because I think that it is really important as we start to use data more and more, as you picked up from a previous slide, that we don't do this behind the back of individuals, but rather that they feel a sense of either individual control or collective control through patient organizations and other networks of patients, that they do have some say in how their data gets used. It's not reasonable to assume that we can just grab data of individuals and do what we like with it and not tell them what we're doing and not seek their approval and so on. So it is important as part of establishing trust. And the Commission does take this topic of trust very seriously.
So you do have on this slide health data for the individual and for the public, for primary use and for secondary use. And what are the points you want to raise here?
Well, thanks very much. So I've got here actually a series of slides that build on this starting circle that explains roughly what is the European health data space vision. And so I've used two colors. The green is really depicting the intention for the data on an individual to travel around Europe in the interests of that individual person. So it's for primary use, meaning it is to support the care of that individual wherever they are in Europe, that they should enjoy the opportunity to have high quality, safe, well-informed care wherever they go. And the blue part of this diagram is about how then can others reuse that data for the many purposes that I described previously. So if you could click again, that the idea is that the primary use data should be held in electronic health record systems, which make sure that data is of reliable quality so that it doesn't mislead people when they access it, and that it should be interoperable. That means it should be standardized so that the different places where an individual might have health data can actually communicate with each other and enable a holistic integrated record to be constructed. And that rather strange acronym EEHRXF stands for European Electronic Health Record Exchange Format. That's a published standard for the health data. And it's important for the citizen that their data is increasingly consolidated. That means it's brought together from all the different places it is now. And people should be able to access their own data for free, never have to pay to get their own data, and that they should be able to write in it. That is, that it's no longer that the patients only look, but that they should be able to contribute their own data into the electronic health records of the future, and they can take that data portable, means they can go where they like and offer that data to a different healthcare organization to take over their care. That national contact points need to be established. Many countries already have these that allow, that act as a kind of gateway to connect the countries so that we have a joined up ecosystem for health data across Europe. Electronic health record systems are certified so that we can trust the data they collect, we can trust the data they receive, and that there are standards for apps that patients might use as well. And an initiative called My Health at EU is like a kind of information superhighway for patients. It's a connector that links all the countries. And the EHDS regulation wants people to be able to exercise control about their data as it travels around Europe. In other words, if you go on holiday from one country to another, suddenly all those people shouldn't be able to access your record unless you authorize it. Or if there's an emergency or unconscious, then it's different. But otherwise, you should have control over who can. People shouldn't have the anxiety that my personal data is wandering around Europe in an uncontrolled way. But then we turn. Sorry.
It's not only for traveling from country to country, but from traveling from Frankfurt to Berlin to go to a different physician or hospital there. Well, it is nice to have the data with you, right?
It is. Yeah. And what we hope is that the green part of the EHDS regulation will help to accelerate also what happens within countries. Yeah. Because it's a bit silly. You're quite right that you can get your data from Frankfurt to Paris, but you can't get it from Frankfurt to Berlin. That would seem a bit silly. And I think that once, for example, an individual country has been able to move the data outside, it should be able to move the data inside. Yes, for sure. But then on the blue side, the analysis universe, that data sets must be quality labeled so that when people get data from another location, they know what the quality of that data is and that it has fair metadata, which means people understand the rules on which they can use it. The EHDS regulation is very strict about the purposes. It lists a set of purposes for which data may be used, and it actually also lists a set of prohibited purposes. So you can't use data unethically. The fees that are charged for accessing data must not be exorbitant. In other words, part of the regulation is to prevent profiteering. People should not see the EHDS as like a marketplace. I can put my data sets into the European marketplace and make lots of money from them. So that's really important. The data should normally be anonymized. That is, you don't know who the individuals are in the data, but occasionally, if you need linkage, you can have pseudonymized access if you get ethics committee approval for your purpose. There are, rather like national contact points, there will be data access bodies appointed at country level who will oversee the provision of data, and that they will have safe havens. That is, if you want to access data, they will put the data inside a secure environment where you can analyze it. Research data sets are not going to be flying around Europe on the internet. They will still be kept securely. And it's also important that these data access bodies are required to be transparent to the public about that.
I'm very impressed with the deep thinking that has been put into this slide already, and I guess there's much more in the respective papers. But I think overall this is well thought through, and the main topics are covered. Particularly data protection is certainly part of this. And I mean, big data is not big data misuse, but it's well controlled how data can be used, and they only can be used in an anonymized way. And again, there's a split between person and system, right? The personal data here and the system data are down here, and this is separate. It's two different approaches.
Yeah. Very much so. And the circular representation is it's my way of summarizing, well over 100 pages of regulatory text. So please accept that there will be some limitations because it's my view. But I chose to highlight the green and the blue to make exactly the point you did, that there is, if you like, an ecosystem for personal data and an ecosystem for anonymized data, almost always anonymized data, which are quite separate, have different rules because they serve different purposes. Yes, absolutely.
And I think on the next, go ahead.
Sorry, the transparency to the public, I think, is very important. If the data is anonymized and there are big blocks of data, maybe 500,000 patient data points in a database that is all anonymized, then you can't actually go and ask people, can I use your data? Because you don't know who's in the data to ask. So we have to then say, for those situations, we can't get consent because it's anonymous. But what we can at least do is be transparent. And that is, we can say a data access body can publish on an inventory, on a web page maybe, we have received the following 85 requests in the last 3 weeks, and we have granted 83 of these requests, and these are the companies or the organizations. This is the area of research they want to conduct, and we've given them this kind of data. We've given them data on diabetic patients in 8 European countries, have gone to this organization that is looking to investigate the issues of safety in a particular topic, for example. And that, I don't know how much transparency can be made available beyond that, but I think even if the public knew that level of detail and always knew there were websites they could go to find out how is health data being used across Europe. I might be in a particular database, I might not, because we can't always be sure, but you get a feeling for whether these uses are comfortable to your moral and ethical principles or if they're not. And I think that's really important. It's hard today for you or me to know how and where our data are being used, even anonymously. But wouldn't it be nice if we could?
Excellent. I like the transparency to the public, and I guess there will be some registry or website where you can look at data or look at what has been done. Let's jump back again to the individual use, and you have an example here on the European Health Record exchange format, which means wherever you are, your physician that is treating you right now has access to the data. This is the summary of this, right?
Yes, absolutely. So this is the vision. I mean, it's not everything that an electronic health record might contain. There are initiatives working on standards and ways of moving the entire electronic health record, but that's very ambitious. It's taking many years to achieve that. So this is, if you like, a fast track. It's saying these are the data areas that seem to deliver the maximum value for continuity of care and safety of care. Let's try and get these right, whilst the whole EHR is taking a slower journey. So there is a summary, a headline of what your main medical points of interest, your prescriptions, which prescriptions have been dispensed, radiology, laboratory, and your discharge reports. If you've been in hospital and been discharged, that's a very useful document usually. So these are the things that are likely to be easily available in an electronic form already. You might call them the low-hanging fruit. And so the Commission has promoted the use of this as a way of jump-starting the comprehensive electronic health record.
Yeah, and I understand you have more ideas about this, and this is shown here, how that could look in the future.
So there's been a lot of work over really almost a couple of decades now, working with clinical professional groups across the world to say what is the headline information in an international patient summary that would be most useful? What is going to make any clinical practitioner safe enough if they see a patient they've never seen before, on whom they have no other records than this? And this is it's well accepted now that you have to know who is the word subject means patient, really. Who is the person, and who are the authors, and who have signed things. But really, what is a summary of the medication, the allergies and intolerances, the problem list, which is the list of conditions you have, your health conditions, what immunizations you have, operations, are there any medical devices that you're wearing? For example, do you have a pacemaker? Are there any test results that are recent and can be viewed by people? Pulse, blood pressure, weight, those kind of things, your respiratory rate, past illnesses you may have had, which may no longer be actively in your body, but they are part of what has shaped your body, pregnancy, of course, things like this. So this is a list of headings that we want ideally, what we would love is that all practitioners worldwide say, whenever I'm documenting in my electronic health record, I will make sure that I keep this summary up to date on each patient, because it has value beyond my own clinic. And then we will have gradually over time a global growth of high value summaries that we can use to look after our patients when they travel. But of course, exactly these data points are tremendously valuable for research too.
Yeah. Look, Dipak, I have this information for myself at age 60 plus, right? I carry this with me all the time. Wherever I go, I have it written in paper, which is totally stupid because data protection doesn't exist. If somebody steals it, it's gone. If I would have it on a memory key, it would be much safer. Or if I would have it some other electronic way in an app or stored in the internet, it would be much safer, right? So paper is the unsafe thing, and this could be the safe thing of the future, particularly the problem list and the summary of all your medical information, right?
Well, you're right, but I think there are two other items, I would say, that go ahead of your paper version. One is that if this is being fed all the time by all the systems that you might ever have healthcare with, this should be more up to date even than your paper, because it should contain the latest things that you might not have chosen to write on your paper. And the second thing is, these are computable. That means when a clinician is going to prescribe you something in an emergency situation when you're on holiday, their electronic health record system can run a check against your existing medications to make sure there's no clash. That's much more difficult if your history's on paper.
Yeah, there is more advantage. There are more advantages with the electronic way because of looking for for things that don't match well, right? Things that don't fit together, like having a type of surgery if you're taking medication that causes bleeding, and all these items is all of a sudden available at your fingertips. And you don't need to ask the patient, who in the end may not even know that his drug may cause a certain side effect that prevents him from one type of surgery or from another medication. So I think this is the benefits is really tremendous. I think data protection can be handled, and I think it is in some countries there may be too much data protection, and the data are protected, but no longer the patient. The patient has disadvantages from data protection. But at the same time, the right use of both, of overprotection and good protection, this is what we really need. I really enjoyed this very much, all the information you gave. I think little is known out there in the public domain. We need to advertise more what is coming, and I wouldn't even say what is coming, but what is needed. We need electronic health data systems, and we need to find a way to make the right use of them. And I think this is my main message from what you told us.
Absolutely. I think that the opportunities for safer, better informed healthcare for individuals is greatly enhanced if we could all have high quality electronic health records at the individual level. And our ability to advance the delivery of healthcare with the best possible advances in treatment innovation, in device innovation, and care planning are only because we need to learn from the data at a big scale. We have to achieve that and deliver those results, that value back to the individuals, so that people get better care because we learned from their data.
Dipak, this was an excellent last word on the topic. Thank you for joining us today. This was our Global Healthcast special on the European health data space. Thanks to Professor Dipak Kalra. Goodbye from Joe Schmitt.
And thank you, Joe, for inviting me. I've really enjoyed our conversation.